Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. This is our second lecture on interceptive orthodontics. So our main reference is chapter 3 from Simon Littlewood and Laura Mitchell, 5th edition. And we will be providing you with some clinical guidelines and some articles. Optional reading, as I told you last time, but mainly focus on this chapter and the handout for this lecture. There are 3 lectures actually on the interceptive. Right, so this is our second lecture. We will be talking about infra-occluded primary molars, eruption cysts, failure and delayed eruption, first molar of poor prognosis. Very important topic. Infra-occluded is the preferred terminology, okay? Infra-occluded primary molars, because are the most commonly teeth that are affected, mainly in the mandible, mainly the second primary molar, the E. Other terminologies could be submerged or ankylosed. How common is this? Well, 1 to 9% of the children will be presented with this. Now, looking at this, for example, this white wing, you can see that the lower right E is submerging. Now, as long as it's above the contact point, this is considered mild. At the area of the contact point, this is considered moderate. This is below the contact point, as you can see here, so this is severe, right? So if we look at this LBG, for example, it's representing very severe submerging of all E's. So you can actually see this E here, this one here, severely submerging, this one here, right? And this one here, severely submerging. So this is a severe case. Right, so clinically, you need to check the mobility of the E. Is there mobility? This is a good thing. That means there is a normal resorption of the roots and the successor is coming through soon, etc. So you need to check for mobility. You need to check for the extent of the infra-occlusion. As we said, is it mild, moderate, or severe? You need to tap with the back of your mirror on the tooth that is ankylosed and on the adjacent teeth until you detect any different sound. Usually it's like tin can sound that will tell you that this is ankylosed. You need to check if this ankylosed tooth is in the lower arch. You need to check for over eruption, usually in the upper arch. And very important, you need to check, of course, to the presence of the permanent successor by taking radiographs, of course. What if you don't diagnose the case or it goes without any management? What happens? What are the consequences? As you know, there will be delayed exfoliation, and this means that you will have delayed eruption of the successor. It might progress, so this condition might not stay still, it might progress and get worse. And this later on, if necessitate extraction, that means this will make the extraction more difficult, more traumatic, and loss of alveolar bone will increase. We will have reduced alveolar bone support as this case progresses. We will have tipping of adjacent teeth, as you can see here, tipping of adjacent teeth. That means we will have spaced loss for any tooth that will be replacing this submerged tooth. We will have areas of food impaction and caries, so we will have damage to adjacent teeth. And as we said, we will have over-eruption of the opposing teeth. Right, so what's the management? Well, as long as it's mild, also moderate cases keep under observation, because luckily the majority of the cases will end up with normal exfoliation and we will have the successor coming through successfully. But if the second premolar is missing or the case is getting worse and the adjacent teeth are about to tip and we have the risk of space loss, then it's important to go for an active management. Most importantly, you have to consult the orthodontist, especially if you have missing permanent successor, because the orthodontist might need this space for future orthodontic treatment for some patients. Extraction of this submerged tooth is indicated if there is a risk of it disappearing below the gingiva. That means it gets really severe, and the necessary extraction will become more traumatic, as we said, with loss of bone. If root formation of the permanent tooth that will come through, the permanent successor, is near completion, okay? Or if, as we said, missing permanent successor and the submerging is progressing, only after consultation with the orthodontist. So is the permanent successor present? Yes. It is present and there is submerging as long as it's at the contact area or above, as we said, then just review. If it's sinking below the contact area of the adjacent teeth, then sometimes we can go for extraction and replace space maintainer, band and loop if it's unilateral. If it's bilateral, then TPA or transpalatal arch. It depends on which arch the problem is. And the space maintainer it's used depends on how much bone is left above the permanent successor and how long do we need to wait for it to erupt. Okay. If the permanent successor is not there and we have submerging of the primary molar, then we monitor as long as it's mild to moderate. And since we have no successor, we can consider occlusal buildup because we know that the E will stay there for a long time. And this can, the occlusal buildup can preserve the contact areas and preserve the space. But if it's going more severe, then consult with the orthodontist and consider extraction. Sometimes if it's really severe and too late, you can go for regaining of space orthodontically for a future implant or use the space for orthodontic treatment. If there is no permanent successor and there is no submerging, then this is a hypodontia case that we covered its management in the previous lecture. Right. Another problem that should be diagnosed early and managed early is the eruption cyst. Okay. It's a cyst that overlies the crown of the eruption tooth and it can cause delayed eruption. Usually it's full of blood or fluid. This is how it's clinically presented. Right? So if it's there, then it's important to check the sequence of eruption and symmetry of eruption. Usually it ruptures spontaneously, but if it causes any problems, then marsupialization is necessary. We need to get rid of this cyst in order to allow normal eruption of the permanent teeth. So this one here affecting the upper right central incisor, and this one here is affecting the upper right permanent first molar. So generally speaking, the problem of failure of eruption or delayed eruption could be early diagnosed if the patient is under dental review every 6 months. You know, we have the ideal patient and we have the ideal dentist who have the knowledge and who can go for the proper examination for such mixed dentition development. You understand, he have the knowledge of the mixed dentition development. So if we notice a problem, usually this is detected by looking at the sequence of eruption and at the symmetry of eruption. So this is an example where we look at this patient. As you can see, the lower incisors, the centrals and the laterals are all permanent. The upper lateral on the left side is permanent, fully erupted, but the upper right lateral is partially erupted. The problem is in the sequence of eruption, right? We have both central incisors didn't erupt and both laterals in the upper and the lower erupted. This is a problem. This is a problem. So we need to look for the sequence of eruption and for symmetry of eruption. Now, if we have a generalized delay of eruption, so we have normal sequence, normal symmetry, but we have generalized delay, this is not a problem as long as it's within 1 to 2 years. Not a problem for generalized delay. Now, delayed eruption, there are local causes and we have generalized causes. You have to look at this box and go through these factors that are considered systematic and local factors, right? So we will move on to which are the most teeth that could be affected by delayed eruption or failure of eruption. Most commonly, the maxillary canine, followed by the central incisors, and finally, the first permanent molars. Now, this problem, if it's going to happen, we cannot fully prevent it, but it's important to early diagnose the problem so that we can have a proper intervention, a proper interceptive measures in order to correct the path of eruption of the tooth, to fully correct the problem, or to know, or at least to reduce the severity of the impaction. Now, which tooth can we identify first? Well, this depends on the sequence of eruption, obviously. Again, if we have the ideal patient who comes every 6 months, then around 6 years of age, between 6 and 7, we can early diagnose the problems of eruption of the first permanent molars. Between 7 and 8, this is the ideal age for early diagnosis of problems of eruption of the maxillary central incisors. Between 8 and 10, this is the ideal age to check buccal bulging of normal eruption of the maxillary canines. And after 10 is the proper time for management, or if there were any problems for such a tooth. So this is early, really. So we're talking about between 6 and 10 years of age, we can detect the problem of delayed eruption for these teeth. So starting with the first tooth that we can early diagnose, which is the first permanent molars. 2 to 6% of children can suffer such a problem. Okay, and luckily, again, most of these cases goes unnoticed, and we will have spontaneous normalization of the path of eruption for the first permanent molar. Another name for impacted first permanent molar is ectopic eruption. Because by definition, when you talk about impacted, the whole tooth is under the gingiva, but actually what happens is that the tooth is locked under the distal surface of the adjacent tooth. It is tilting or leaning against the adjacent tooth, so we call it ectopic eruption. So this is another terminology for an impacted first permanent molar. Now, it's important to classify the severity of the first permanent molar impaction or ectopic eruption, right? So if, as you can see here, if we have limited resorption of the cementum, minimal dentine penetration, this is a mild case. And for mild cases, that is considered grade 1 ectopic eruption, we usually put the patient under observation, and it can go spontaneous eruption for such cases, spontaneous eruption. If the patient is less than 8 years of age, then we just keep the patient under observation. But after that, then spontaneous eruption is not really possible. So we need to intervene. We need to actively manage the case by applying separators. Separators, there are 2 types of separators, the elastic separators that we force between the teeth to open the contact point, or metal separators with a brass wire, where you actually insert the wire around the contact point and just twist the wire, ligate it and make it tight. And every week, the patient comes back to retighten the wire, and you continue doing this for about 2 months, and usually most of the cases the problem will be resolved. As you can see here, this is the second photo here. When you have resorption of the dentine, but without any bulb exposure, then this is grade 2, which is considered moderate. It's important to go immediately into active management by active distalization of the first permanent molar in order to normalize its path of eruption and to stop the damage that it's causing to the E. So this is the second primary molar. Here is resorption of the distal root of the E leading to pulp exposure. So this is a severe case considered grade 3. And this is grade 4 where we have resorption that affects the mesial root of the primary second molar. These two severe and very severe cases will require extraction of the E, allow eruption of the cysts for about 6 months or so, and then active distalization of the first permanent molar in order to regain space, and then you fit a space maintainer in order to allow the space to be maintained for the second permanent premolar, right? So we have a priority for the to give a chance for the eruption of the first permanent molar, and the second priority is to provide space for the second permanent premolar, right? So again, with early diagnosis, we can keep the patient under observation, and most of them will go spontaneous correction, but rarely after 8 years of age. Mild cases, brass wires tightened, as we said, over 2 months. These are the brass wires, and this is how we insert them. We tighten, we twist the wire, and every week the patient comes back to retwist, and we keep doing this for 2 months. Right, more severe cases, unfortunately, as we said, we have to extract, like this case here, for example. This is a severe case. This is a grade 4, right? So we have to go for extraction of the E, allow time for the first permanent molar to erupt, and then distalize the E to regain space for the 5 and fit space maintainer. This is how we manage this case. The upper left 6 actually looks less severe, so this is considered mild to moderate. So we can go for brass wires or elastics as a separator. We go for 2 months, and if it responds, then this is good. If not, then we have to go for active movement or distalization of the permanent first molar. Right, so this is a case of a patient who is, this is a patient with in the mixed dentition, and as you can see, this is the E, and this is the first permanent molar, as if partially erupted, but actually, if you look at the radiograph, it is locked under the E. I think this was taken later, even with the 7 developing properly. Right, so what do? We have to go, this is considered mild. We can go for brass wires and monitor weekly over 2 months. This is unfortunate patient who didn't have an early diagnosis. So as you can see, this patient is in the permanent dentition. Even the 7 is fully erupted, and 6 is submerging ectopic eruption, and it's really getting worse. Right, now we come to the unerupted maxillary incisors. The most common cause for impacted immediate eruption of the first of the central incisor is, as we said, the supernumerary in specific barrel-shaped tuberculate. Okay, so if you diagnose the case early and you actually saw that the problem is due to such a supernumerary, then its removal will allow about 90% of the cases to have normal eruption of the central incisor. The later the diagnosis, the more difficult is the management. So you need to know the etiology. You need to diagnose the case. Trauma is another option. Trauma to the tooth with the deflection of the developing follicle, dilaceration, ankylosing, thickening of the gingiva. These are the etiological factors that are related to delayed eruption of the central incisors. Now, there were guidelines that were published in 2016 in the Royal College of Surgeons of England, guided by Yaqub, and this was republished in the British Dental Journal 2018. Same research team, but this time Sihra was the first author for such a review article. So these are national clinical guidelines for the management of unerupted maxillary incisors. Okay. Now, there is a difference actually between 2016 and 2018. The difference is patients who are younger than 9, where the roots of the central incisors are not completing yet, we need to diagnose the problem first We need to make sure that there is enough space. Then we remove the obstacle and we wait 9 to 12 months. But if the patient is older than 9 and the root is almost completing, then first we make sure that there is enough space. We remove the obstacle, but we don't wait. We go for exposure and attachment to prepare the patient for orthodontic traction. Okay, we don't wait here. Now, if the case was severe and the patient needed general anesthesia, then it's important, even the patient, if the patient was younger than 9, then we need to make sure to avoid multiple procedures. So if we need general anesthesia, then we go for removal of the obstacle and attachment. We bond an attachment, okay? Because we need to avoid multiple procedures for the future. So this is a patient that we talked about, delayed eruption of both central incisors. This patient had history of trauma. Luckily, there were no supernumeraries and only thickening of gingiva. Okay, the one on the upper left quadrant, simple incision was enough, but the one on the right quadrant, when the incision was made by the pediatrician, what happened is that there were a small eruption cyst that was removed as well. So a few weeks later, you can see that the left central incisor erupted nicely and the right one had a little bit of delay, but it did follow nicely later on. No any traumatic surgical procedures was necessary. Once you know the etiology, you exclude supernumeraries, then it's easy to treat the case. The other most important factor is early diagnosis. This is another patient that was actually diagnosed kind of a little bit early, you know, because once the central incisor erupted on one side, the other didn't erupt. This should be an alarming signal. Also looking at the lateral incisor erupting, and yet the central incisor hadn't erupted yet. Again, this patient should have been seen earlier. Never mind, the patient is still about, I think, 9 years of age, and the etiology of the impaction, as you can see, we have plenty of space for both central and lateral to erupt. A combeam CT scan showed that the patient had supernumerary, preventing both central incisor and lateral incisor from erupting. So the management is to first make sure there is enough space already. Yes, done, tick. Remove the obstacle. The patient had to have simple surgery and extraction of the supernumerary because it was closed. And just wait for 9 to 12 months. And after that, refer to the orthodontist if no eruption has occurred. Right, so now we come to the third tooth that we can diagnose with a problem, which is the impacted maxillary canine, and it is the most commonly impacted tooth. Right, between 8 and 10 years of age, it's very important during the regular examination of the dental development of children is to put our fingers at the buccal sulcus there. Okay, we start in our finger on the lateral and we just go all the way along its root and distally. So the canine is guided by the distal surface of the root of the lateral incisor. And we suppose between 8 and 10, we're supposed to see or to feel buccal bulging. This is the typical normal buccal bulging of the erupting canine. It's supposed to be there and it's supposed to be symmetrical. So if we have lack of bulging up to the age of 10 or we have asymmetric bulging, then this is a problem. Especially if there is family history of impacted canines, dental anomalies, these are alarming factors, right? So if there is asymmetry, as we said, or no bulging, then we take further diagnostic methods like radiographs in order to assess the problem. Okay, so this is the area of bulging of the canine, as you can see, exactly. Right. Now, if on the radiograph you actually identified a problem, then we need to go for an early management for such a problem. And usually the management is after 10 years of age. So as you can see here, for example, if this patient you went for clinical examination, then on the upper right quadrant, you will feel the bulging of the canine nicely. So this is normal, okay? You need to check for mobility of the C. You need to check for the dental development in general. Everything looks normal on the upper right quadrant, but the upper left quadrant, obviously, the canine is shifting to mesially, and it bypassed the roots of the lateral, and it's going toward the central incisor, and it's not possible to feel the bulge of this canine buccally. Okay, so it's because it's palatally impacted actually. So what's the management in this case? In cases where we have enough space, uncrowded case, there is enough space, there is no crowding, then we extract both C's and we review the patient every 6 months. It is expected the first 6 months to have 64% of the cases with normalization of the path of eruption of the canine. Within the first 12 months, 78%. But then after that, no progress will be really noted. It's not possible to see further progress. If the case had not enough space or there is obviously crowding within the arch, then it's important to provide space by expansion, headgear with distalization, and after that you fit TPA with NANS, you fit a NANS appliance for space maintenance. It's like an anchorage for space to maintain the space, and then wait for the eruption and normalization of the canine. At least, if it doesn't erupt, then the severity of the impaction will reduce. We will have some normalization of the eruption path of such cases. Okay. So this is a patient who attended our clinic in the late mixed dentition. The upper left canine was almost normal, a little bit shifting distally and overlapping the lateral incisor. The upper right canine, the upper left canine was in a more severe position, and it did actually overlap the whole lateral. So we sent the patient to the dentist to extract both C's and review the patient in 6 months, and unfortunately the patient came back where the dentist actually extracted both C's and extracted the upper left permanent canine. And when I asked the parents why this happened, they said that the dentist told them that this impacted canine will never erupt, and it will only cause problems, and it will cause delayed of orthodontic treatment. So this was unfortunate case, and I had to show you this because you're gonna graduate, inshallah, within a year and few months. Let's say, yes, actually, in a year and few months to become general dentist. So please respect the development of the occlusion and the erupting permanent teeth. And if you were in doubt, please refer to the orthodontist. Okay, this is a killing mistake for such a general dentist. Right, so let's come for this patient who was lucky with the beautifully educated parents, because once they noticed that this lateral incisor is erupting like this and the other one is like this, tilting severely, they came immediately for orthodontic consultation. And they were right, okay, because the problem was a canine that was pushing against the roots of the lateral incisor, causing such displacement. Okay, so just by looking at this ugly duckling stage, this is not normal. The upper left quadrant is showing the normal ugly duckling stage, the normal mixed dentition stage of an erupting canine. But the upper right quadrant, this is too much, going too severe, let's say tilting or fanning of the upper labial segment. So we went for comprehensive CT scan because we were worried about the root of the lateral incisor, but the patient was lucky. There was actually a bit of dilaceration, but there were no resorption. So our treatment plan was to provide space by simple removable appliance for expansion, and we kept the same appliance in place as a space maintainer, and we extracted both C's. Okay, and after that, when the canine erupted, we went for fixed appliance in order to align the teeth. So the case was treated beautifully. The severity of the impaction was reduced tremendously, and the patient had a successful treatment. Now, let's look at unfortunate patients who were not early diagnosed, like this case here. You can see that the upper right canine was severely palatally impacted, and it was pushing against the lateral incisor that was severely displaced. But again, the patient was lucky. You know, we could have a severe resorption of the lateral, but there wasn't. There were no signs of any resorption. They were actually remaining root of the C. When could I have diagnosed the problem? Early, between 10 and 8, as we said. We would be feeling the bulge of the upper left canine, no bulge of the upper right canine, and then we could have diagnosed the case and went for some interceptive measures. This is a beautiful study case. As you can see, this patient, looking at the dental age, you can see that the sevens are fully erupted. The roots are not completed yet, so this patient is 14 years of age. Looking at the dental age, as I said, what's the problem in the upper arch is a retained deciduous canine on the upper right quadrant with an impacted, severely impacted canine because it has bypassed the lateral and almost bypassed the half of the root of the central incisor. In the lower arch, we have an impacted lower left second premolar, and the etiology is related to an early loss of E. So 14 years of age. Let's go back 5 years. So let's say that the patient came to our clinic and she was 9 years of age, and we were the dentist who had to extract the E because the lower left E because of poor prognosis. What could we have done to avoid such a problem? We could have fitted a band and loop in the lower left quadrant in order to maintain the space, and then the patient will not be presented with such a problem. In the upper arch, as we said, between 8 and 10, we could have noticed asymmetry of bulging, and we could have taken an early OBG and diagnosed the abnormality in the back of eruption of the upper right canine. And then what could we have done? Extraction of both. If there were no crowding, then extraction of the C's, and review the patient every 6 months. If there were crowding, provide space and put a space maintainer, and then to be more specific, not space maintainer, NANS in specific, okay? A NANS appliance. It looks like a TBA but with an acrylic button behind the vertical part of the palate behind the upper central incisors. And then we wait for the eruption of the canine. And again, this case that came with severe impaction could have been converted to a case with a simple malocclusion that could be treated within 9 months to 1 year. But this patient needed an extensive orthodontic treatment. As you can see in the lower left quadrant, we had to open the space for the second premolar. In the upper right quadrant, we had to open space, extract the C, and then as you can see, the canine was bulging palatally. We went for exposure and alignment. Right. Another case that is really interesting, again, a patient who is presented with about 14, 15 years of age, full permanent dentition except for the lower right 5 that was impacted due to early loss of E, congenitally missing upper lateral incisors, retained upper left B, upper right C, and impacted canines, severely palatally impacted. Okay, so could we have done something when the patient was younger? Definitely. Again, 9 years of age, let's say roughly, is a good age for a space maintainer for an early loss of E, and this problem could have been gone, not there, and we could have diagnosed missing lateral incisor around 8 to 9 years of age. We can diagnose a missing lateral, and then we could have gone for an OBG to check for risk of impaction of the canine, and then we could have applied an early extraction of the deciduous teeth in order to enhance normalization of the position of the canine. Anyway, so this is a patient who was not treated early and again needed an extensive treatment. You can see here the 5, we opened the space for the 5 and it erupted nicely, and we opened space for the canines, but they had minimal response. We had to go for exposure, alignment, and closure of all spaces and accepting the canine in the place of the lateral incisors. Right. Now let's come to our last topic, which is guideline for the extraction of first permanent molars of poor prognosis. Okay, this was published in 2014, and then it was republished recently in March last month, before a month and a half almost. And it's a guideline for the extraction of first permanent molars in the Faculty of Dentistry of Surgery guidelines, Royal College of Surgeons of England's guidelines, right? Coburn was the research leader here, and it's nowhere but the same research group, as you can see, right? To be honest, both guidelines, there were minimal differences, but I noticed that this guideline here, the most recent one, was more clear regarding the evidence-based recommendation, let's say, take into consideration the recent articles. Right. It's important to know what do we mean by poor prognosis. A cyst of poor prognosis means a cyst with such hypoplasia, as you can see, like in cases of MIH, or cases with caries that actually affects two surfaces or more. Okay, caries or restorations that involve two surfaces or more. Okay. I just want to remind you, by balancing extraction and compensating extraction, balancing means to extract the same tooth on the other side of the same arch, okay? Or compensating extraction is to extract the same tooth in the opposite arch on the same side, right? Now, you need to know the difference between elective extraction and enforced extraction, and you need to understand what do we mean by optimal timing of extraction. Optimal means the ideal timing for extraction. And of course, the opposite is either too early or too late. So we need to understand these terminologies. Let's start with the enforced extraction. Enforced extraction, that means we had no choice. There were acute pathology, severe pain, we could not temporize the tooth, and the only management was to extract. So it's obvious that we did not have enough time to go for proper planning. So we go for extraction, and then we assess future options accordingly. When we say elective extraction, that means this is the ideal. We temporize the problem, we manage the pain, and then we refer the patient to the orthodontist for consultation in order to have a proper planning for the needed extraction. So this is elective extraction, extraction after proper planning. The gold standard is to have a combined orthodontic and pediatric services to allow comprehensive treatment planning, okay? And also the gold standard is to discuss all these details with the parents and the patient. And although we can give the patient the ideal recommendation and the ideal guidelines, but sometimes the patient and the parents will refuse any management that includes extraction, especially of permanent teeth. On the other hand, you will have parents and patients who will actually refuse the idea of a future prosthetic work or heavy restorations or endo treatment. They prefer to have a normal, natural dentition with no fillings. So it's important to go for a proper discussion, and at the end of the day, it's a shared decision-making process. Okay, it's not your decision, it's not the orthodontist decision. We give the patient enough information and proper education of the problem, and then it's their decision to make after our advice. Right, let's come to what we mean by optimal time. Optimal time for what? If we have a cyst of poor prognosis, or if we need to extract the cyst for whatever reason, then it's important to choose the time where the 7 can replace the 6 with minimal consequences. So at the end, it looks like there was no missing 6. The 7 comes in its place with minimal consequences. So this is what we call an optimal time. Okay. Now this optimal timing is more critical in the lower arch than in the upper arch because of the quality of bone and the direction and the angle of eruption. On average, the ideal time goes from a chronological point of view between 8, and 10, but it's extremely important to look for the dental development age of the patient. Okay. Now, what are the criteria for the optimal time? Number one, we need to look, of course, these are things that we look at on a radiograph, on an OBG, right? So number one, we need to look at the bifurcation area of the 7, just starting to calcify, okay? And then the angulation between the follicle of the 7 compared to the 6, the angle should be around 15 to 30 degrees. And then we need to have the follicle of the 7 just overlapping the distal root of the 6. These are the ideal criteria for the optimal time. Finally, it's extremely important to have evidence of developing wisdom, because at the end of the day, if we're going to extract the 6, that means we will end up with 2 molars. Ending up with 1 molar only could be a problem. So it's important to have the presence of the wisdoms taken into consideration when we make this decision. So again, what is the optimal timing? Looking at this case here, we have a 6 with full prognosis. Taken into consideration, we have a 2 surface area. You can see the follicle of the 7 developing. So we have the bifurcation area just starting to develop. This is good. The angle between the long axis of the 6 and the long axis of the 7 is 15 to 30 degrees, acceptable. We have a little bit of overlap between the 7 and the root of the distal root of the 6, excellent. And the bonus, or actually it's not a bonus, it's an important factor, where we have the follicle of the wisdom is developing, and this is good, excellent. This is an excellent case to extract the 6 and allow the 7 to erupt in its place with minimal consequences. Right, now we come to the other extreme, which is early extraction. Early extraction, that means before the optimal time. Sometimes it is really an emergency and the patient is in pain, there is no other option, we have to extract the 6. What happens? What happens is that as a consequence of its early extraction, the second premolar will shift and drift distally into the extraction space, and it will tip and rotate. The labial segment can retrocline with an accompanying increase in the overbite. So this is a problem. The other extreme on the other side of the issue is the late extraction. What if we had a case that is beyond, after the optimal time for extraction? What happens is that we'll have mesial tilting and lingual rolling of the second molar, over eruption of the opposing 6, distal drifting and tilting of the second premolar, incomplete space closure, atrophy of the alveolar bone as well. So you can see here the 6 of full prognosis, but this is the permanent dentition. Obviously, we have all permanent teeth had erupted. So you can see tilting, lingual rolling of the second molar. We can have over eruption of the opposing 6, as you can see here, and atrophy of bone. Right. Now, in the upper arch, as we said, the optimal timing is less critical. We still have consequences, but it's less severe compared to the lower 6s. And actually, if you lose the upper 6, we rarely have over eruption of the lower 6. Now, what are the factors that will affect the decision of extraction if you had a patient, a child with a 6 of poor prognosis? Well, these factors are divided into factors related to the patient and factors related to the occlusion. Factors related to the patient in terms of patient's capacity to comply with this complex treatment. Are they willing to go through the treatment, maintaining excellent oral hygiene? And also it depends, of course, on the patient's dental age. Now, some features of the mal-occlusion will actually affect also our decision, and this might include the skeletal pattern of the patient. Is it class 1, 2, or 3? It will make your decision different. It will affect your decision. Do we have crowding or not? Do we have missing teeth, ectopic tooth positions, presence or absence of the third permanent molar, the wisdoms? Assessment of second permanent molar development and angulation will have a significant impact, of course, on the treatment of choice. As a general rule, if you have a first permanent molar of poor prognosis and the space provided by extraction of this tooth is not necessary for orthodontic treatment to relieve crowding or for orthodontic treatment to camouflage certain features of the malocclusion, then it's important to choose the optimal time for extraction. Okay, so this is the general rule. If the orthodontist doesn't need this space to relieve crowding or to camouflage the malocclusion, then it's important to choose the optimal time so that the second permanent molar will replace the first permanent molar spontaneously with the minimal consequences, no active intervention. Now, let's look at the guidelines related to class 1 malocclusion. If the patient is presented with a class 1 malocclusion and there was minimal crowding, that means I don't need the space for orthodontic treatment, then I extract the 6 of poor prognosis at the optimal time. I do not balance, and I compensate only if the extraction was in the lower arch. And here I have to put 3 red lines because there are some recommendations in the new guidelines that will tell you that do not compensate unless there is a very specific justified reason, okay? And this is judged by the orthodontist, by the specialist. Right, what if we have some crowding in the buccal segment? That means we need the space for orthodontic treatment. If the crowding was mainly in the buccal segment, not in the labial segment, that means the extraction is exactly where I wanted. So that means I can go for an optimal extraction at the optimal time. And if we have crowding on the other side of the arch, then I can go for balancing extraction. And again, compensation is debatable here. If the crowding is in the labial segment, that means the extraction is not really relevant. It's away from where I want it. That means I need to postpone the extraction of the 6 of poor prognosis until the eruption of the second molar. Why? Because I will apply some space maintainer on the second molar, use the space of after I extract the first molar to relieve the crowding, and then after that I close all spaces. So I need to postpone extraction. How? By temporizing the 6 of poor prognosis until and manage the pain until the 7 is fully erupted in that quadrant. Okay, and of course I need to look at the presence of third molars. So the recommendation is when the enforced extraction of the lower first permanent molar is required, compensating extraction of a sound upper first permanent molar should not be routinely carried out. If the upper first permanent molar is sound, that means there is no caries, okay, and it's a good prognosis, then you do not extract for routine management to avoid over-eruption. Unless there is a clear occlusal requirements or likelihood of the upper first permanent molar to stay there unopposed for a long time. Okay, so these are recommendations based on scientific evidence in the new guidelines. Routine balancing extraction of a sound. Again, when we say sound first permanent molar, that means a molar that has no caries, no hypoplasia, of good prognosis. Okay, to preserve the central line is not recommended unless part of the comprehensive orthodontic treatment plan requires such extraction. Right, so first permanent molar of poor prognosis, let's take this example. This is the tooth that we talked about, lower first permanent molar on the lower left quadrant with poor prognosis, and on the same quadrant we have crowding. We have early loss of E, an impacted 5, an impacted canine compared to the other side. Okay, and the upper right 6, as you can see, had a simple filling where we actually referred the patient for restorations, and we extracted the 6 because it was at the optimal time. It was at the optimal time. So unfortunately, after 8 months, around 8 months, the upper right 6 was not properly filled, and we had a bigger filling that occupied 2 surfaces, so we had to go for extraction of this 6, although it was beyond its optimal time, but actually because it's the upper arch, this was less critical. We had less critical consequences. So as you can see, almost less than 2 years after the extraction, you can see the 5 fully erupted, the canine fully erupted, and the 7 fully erupted in the place of the 6 as if there was no extracted 6. So beautiful 7 replacing the 6, and here you can see the 7 is actually replacing the 6 of poor prognosis. And this radiograph was taken after that. And this is the 7, and this is the 7 in the upper right quadrant. Acceptable results. Right, so this is an unfortunate patient who was not properly diagnosed, and you can see again severe crowding and very poor 6. If this patient was presented around between 8 and 10, then an extraction of the 6s on the upper right quadrant and balancing extraction of the upper left quadrant in order to relieve the crowding. Actually, part of the etiology is early loss of E, so you could have placed band and loop on this side. An extraction of text if it was that of that poor prognosis at that time. Right, let's talk about class 2 malocclusion. Patients with a class 2 malocclusion, as you can see here, need more space in the upper arch in order to have a camouflage of the increased overjet, to reduce the overjet and to correct the malocclusion. So orthodontic treatment requires space in the upper arch, okay? And so if we have minimal crowding and the 6 of poor prognosis is in the lower arch, well, I don't need any space orthodontically to correct the class 2 division, class 2 malocclusion, okay? So in the lower arch, I go for optimal time extraction. I do not compensate and I do not balance, okay? And the upper arch, if the 6 of poor prognosis was in the upper arch, as I said, I need space in the upper arch, so I don't extract it at the optimal time. No, I wait for the second molar to erupt. I hold the second molar with an ounce, for example, some space maintainer, or it depends on the case, a functional appliance or whatever. And then I extract the 6 and use the space of the 6 to camouflage the malocclusion. Okay. Right. If I have crowding, then again, I need to maintain space in the upper arch and in the lower arch in order to use the space of the extracted 6 in order to correct the malocclusion. Okay, and to relieve crowding. To relieve crowding for an orthodontic treatment, or I need the space to camouflage malocclusion, then I need to postpone the extraction of the second, the extraction of the first permanent molar of poor prognosis until the second molar erupts. Okay. Right, so this is an example of a patient presented with the class 2 division 1 malocclusion, increased overjet, and luckily the 6s of poor prognosis were not extracted. Okay, and now I can actually place nance on the 7s and then extract the 6s and then use the space to camouflage this malocclusion. Class 3 malocclusion, extraction of maxillary molars should be avoided. Balancing and compensating extraction should be avoided, is not recommended. A patient with a class 3 should be referred to the specialist. These are difficult cases to be treated. Okay. So this is an example of a patient, class 3 malocclusion, increased vertical proportions, all 6s of poor prognosis, and this is the excellent time where we have fully erupted second molars, and I can use the space orthodontically by extracting all 6s and correct the malocclusion. So please, class 3 malocclusion, refer to the orthodontist for consultation. Okay, so this was a lecture on the interceptive orthodontic topic, and the rest of the topics will be covered in our coming lecture. Thank you for listening.